It's time for us to start the Health Committee. It is 12:15, and I'm going to ask Counselor Frankie Hargis to give the invocation, please.
Heavenly Father, we thank you for this beautiful day you have blessed us with. We ask that you just guide us and direct us through this meeting, and that the decisions made are in the best interest of the people. In Jesus' name we pray. Amen.
Amen. Thank you. And Ms. Shelley, will you call the roll, please?
Jeanette Woolright.
Present.
Dick Lay.
Here.
Bill England.
Here.
Jack Baker.
Here.
Joe Bird.
Anya.
Julia Coates.
Here.
Jody Fishinghawk. Here. Dave Fraley. Don Garvin. China Glory Jordan. Frankie Hargis.
Present.
Chuck Hoskin Jr. Lee Keener. Curtis Snell.
Here.
David Thornton. David Walkenstick. Kara Cowan. We do have a quorum.
Thank you. First, the chair will entertain a motion for approval of the minutes.
Make a motion to approve the minutes.
A motion been made and
Second.
seconded. And all in favor of the minutes being approved? Saying aye. Opposed, same sign. Okay, the minutes are approved. And reports, Claire Moore is first. Yes, ma'am.
I'm subbing again today.
Welcome.
I'm Vicki Snell. I'm the hospital administrative officer, and George had sent you a report, I think, I hope, and just a few highlights for this month is we were successful in raising our immunization for the flu in our healthcare workers. We were only at 78%, and the area was wanting us to try to increase our percentage of healthcare workers that get vaccinated. So we set a goal for 80% because last year we were at 78%, and trying to educate staff why it's important to get it. And so this year, our goal, and this is as of today, we are at 90%. So we have already reached the healthy people 2020 goal of 90%. So our goal is to try to maintain that all the way in the next few years to keep it at that high level. So to date, we have given over 7,000 flu vaccinations to our patients. We still have flu vaccine available. It's out there. We've even set up a clinic just for a nurse. You can go straight to the nurse. We've made it as easy as you could get it. You come in, you go straight to her. She'll give you the shot and you're out. So we are trying to use up all of our vaccine so we don't have any that's left over. And as far as recruitment, we are still recruiting for a couple of ER physicians, one OB/GYN physician, and optometrist. We have an optometry vacancy at this time. Any questions?
Councilor Lady Watts.
Thank you, Madam Chair. On the flu vaccines, do we just need to tell them that they need to be an existing patient with their chart number to come in with that kind of ease?
If they're eligible and need one, we'll take them and make them a chart.
Okay.
Yeah.
And they just need to check in the operator's
Or the registration.
registration.
Yeah.
Okay, thank you, Vicki. Appreciate it. Thanks for being here.
Yes, Councilor Keener.
Thank you, Madam Chair. How long did, or how late, I guess I should say, in the spring do they take a flu shot, or when's the flu season
We usually
over?
do September through March.
March.
We'll continue to push that and try to use up that vaccine by the end of March.
Thank you.
Any other questions or comments? Thank you. Our health director, Ms. Connie Davis, is still under the weather just a little bit. She's had a time with her bronchitis and everything, so she's still on doctor's orders to stay home, and so I'm sure Dr. Montgomery's going to give us a good report.
Hello, everyone. And I was
I need to say that Ms. Davis, I'm sorry that she was not able to be here, but she was hospitalized last week with complications of influenza, but has done well and has returned home and hopefully be back to work tomorrow. Hopefully you all have a report in front of you. I'll ask if there are any questions about what's in that report.
Councilman Thornton?
I don't think it includes about what's in it, it's what's not in it. It doesn't have the visitation per clinic. I haven't seen it in here, what good? Most of y'all Hastings, the third party, but I can't find a visitation per clinic. I see a price per clinic, maybe the visitations at clinic. A third-party revenue on the clinics, but
Right.
not a visitation.
You're right. He has a total ambulatory patients per year, but not broken down by clinic. You're right. Well, actually, no, maybe we don't have the same report, but this report does have it broken down by clinic.
Maybe I didn't look at that. Thank you.
It's there.
Councilor Garvin?
I noticed you got some calls about the inhaler, Advair, going to be replaced by some kind of spray. Can you kind of explain why? And some of the people don't want to change, but I don't guess they have a choice.
On the end, I'll defer this to Mr. Sanders, but it's still an inhaler. It's the word we use for the type of inhaler that Advair represents is it's a steroid inhaler. It's what's called a long-acting bronchodilator. And the replacement inhaler is essentially, fundamentally, the same medications. It's a little bit different device. It's a little bit different actuation device. But it's fundamentally the same medicine. It's not a change to something really, truly different. Mr. Sanders, do you mind addressing that also?
Good afternoon. To answer your question, the change in the inhaler at this point was actually something that was done not just by us, by Indian Health Service as a whole, and due largely in part because the two medications are very similar in activity and how they work. There's a little bit of a difference in the inhaler itself and how it's delivered, but the medications are the same. The biggest portion of this, though, was due to a cost differential. Advair had actually gone up 2 times over what we paid previously, and the contract for Dulera, which was a new one we picked up, had reduced in price 50%. This savings to Cherokee Nation alone is going to be in the $2 million neighborhood per year. It's a huge amount. And the efficacy of the inhalers and the studies that are done all show everything is equivalent across the board.
So we can tell them they're going to get about the same results.
Absolutely, yeah. And we will monitor things like that anytime we make changes. If there are actually problems with that change at the patient level, then we would re-review, the switch of medications. But the studies and everything that substantiate these medications, there's no difference.
Both come from the same company?
No, they're manufactured by different companies. GSK is who actually manufactured Advair, and Merck Sharp and Dome is the one who manufactures the Dulera.
Councilor Kidder, did you have your hand up?
Yes.
I'm sorry if I skipped you. Go right ahead.
Okay, that's fine, thank you. I had a question, I don't know if you would answer this, on the funding initiative update, the 5%. I understand, or I think I understand that it says the referrals are termed call-in. To get that correct? Is that correct? Okay. It's treated as an emergency to bypass the system? Is that?
Let Mr. Hayes address
Okay.
Those are referrals that are unscheduled. So if somebody doesn't feel well, the ambulance is called, and they're taken to an emergency room that's not Claremore or Hastings, then it's an unscheduled referral, and it's termed a New York call. So there's a lot of those.
Okay.
So they're not scheduled.
Okay, and so I guess, well, it says the reason for that is to bypass the critical IHS route.
Well, that's not the reason, but it bypasses the IHS route because it's unable to be pre-planned and pre-budgeted and those kind of things.
Right, okay, good, I just want to understand.
Yeah, because it's not something you can, if you're having a heart attack, it's not the payment is considered after the fact.
But these are for dentures and eyeglasses, is that not right? That would be emergency?
No.
Okay, well, the way it's presented, it looks like these referrals, maybe I'm just reading it wrong, it looks like the referrals are for those sorts of treatments that are treated as emergencies, but that's not correct. Okay, and I may have just misunderstood, I just wanted to understand. Okay, thank you. Thank you, Madam Chair.
Councilor Hoskin.
Well, thank you, Madam Chair. Doctor, I just want to commend you for the implementation of the pay raise. It wasn't but a week or two after you presented it to this committee that the Veneta facility hired or got close to hiring 2 Cherokee doctors. Not just 2 doctors, 2 Cherokee doctors. And that's wonderful, and I appreciate the impact that had on that facility. And I understand that that's happening all over, that we're filling positions all over as a result of that. Is that correct?
That is correct. The adjustments in compensation were, we started utilizing them in what are called letters of intent for potential hires in the future. I thought that was an important strategy to go ahead and implement before the final pay scale was actually approved. I take responsibility for that. I stuck my neck out, and I thought it was an important thing to do. The numbers that I've told you in the past is that we've had a vacancy rate of between 7 and 8%. Now, the exact number of providers in our systems we can discuss, 298, 300 positions within our health system. That boils down to about 28 to 30 providers that we've had vacancies for over the last several months. With this adjustment, with the letters of intent that have been distributed, our projected vacancy would be 15 in the next few months. That, to me, is a significant reduction. Now, could you attribute some of that to just chance? Sure. Maybe there were people just waiting in the wings. But the feedback that I get from health and recruitment is that these people were waiting on that change to make the decision to pull the trigger on signing that letter of intent. And I have to, my job is to be optimistic. And my job is to say that I think with this adjustment in compensation, we'll see vacancy rates in the single digits in the next 3 to 6 months. If we don't, then maybe I'll, but I'm just confident. I want to, again, thank you all for your vote of support at the last meeting, because that's the reason I told you this was so important. You all know this, but I'll say it one more time. Fewer vacancies, more providers means more Cherokee citizens, more Native Americans being seen that don't have health insurance, that don't have access to care. We will have this dialogue ongoing about improving access and maintaining our access. But again, thank you for your support at the last meeting, and I think that you're going to see the benefits of that support by the vacancy rate being lower.
Thank you, Doctor. Madam Chair, I have a question for Brett Hayes, if he is still with us. Are we seeing just kind of a seamless flow of information from Claremore to your office about contract health, deferrals, denials? Are you getting that information from Claremore? That's how I always thought it was supposed to go.
Yeah, well, we run the reports out of there, and sometimes we have to get back in touch with Claremore to get more information for the referrals. That's the process we're working on.
Okay, I just want to make sure. Thank you, Mr. Chair.
Councilor Ray.
Thank you, Madam Chair. I got a constituent who called about ventures, and I guess we're going to do making sure income, and if they're over income, then it's about $700 for the venture. I had 2 questions, and I talked to Dr. Jones earlier, but I get, is the show of income a policy guideline? I think is what I'm hearing.
That's really, I'm going to ask Dr. Jones to address that.
And also the question would be, why don't we use 5% for the $695 venture?
Okay. I've got a copy of the policy that's been in place, and I'll just pass those around. Didn't get it in your packet, and I didn't know I was going to need to bring it till. And I think we should make a copy for everyone. But typically, on the denture program, they have to be a Cherokee citizen, they have to live within the 14 counties, and they have to show an income level. An income level has been adopted from the WIC guidelines, and it was used for eyeglasses as well. It's 185% of the federal poverty level. So that's where that was set up. And they do have to bring verification and show that. They have to be willing to show us a proof of where they live, and then if they fit in those guidelines, of course, then they're eligible for that program.
And I guess, we talked about, did the program start with the resolution and then the policy guideline came later? Or was there just a policy guideline that was done years ago? You said it was updated in 05?
That's when this policy was put in place in 05. My understanding is it goes back to 1996, somewhere in that, when the fuel tax money became available. That's where this was set up.
And to me, dentistry sounds like healthcare. You're saying maybe it's, with this policy, maybe it's not?
The funding for it came from a different source for this program, from the fuel tax monies that were put into, and maybe Mr. Hayes can answer that for us. So, I mean, that's before my time. So
Initially, I believe, I started in 04, so this is before my time also. The fuel tax is what we termed it, was general fund that was somehow related to taxes on, I think, like the gas station fuel was sold. So that's what they funded dentures and eyeglasses and Merck with at that time. And now it's all general fund, but we still...
It's all gen fund now?
I think it is, yes. But it's
Okay,
still...
So why are we asking, if it goes to gen fund, I guess a good question is why are we asking for income? The other question is, why don't we pay that with the 5% program, which says eyeglasses, dentures, on and on? I don't understand why we're not spending that fund, which is now, I don't know how many million.
That's something we...
On the denture program.
I think we budget, I'm going to guess, because I didn't look at it before I came today, about $1 million a year for dentures and eyeglasses and things. So, just historically, we've always used 185 FPL to manage that. You're making good points about it. Do we want to...
Are we going to have to change that to council, or if it's policy guideline, you guys can change it, I believe.
We're doing some research right now to find out if it's policy, if it's something that requires guys to do it. I don't know that for a fact. And we started researching it this morning, so.
And I appreciate that, Madam Chairman. I'd like to put this on the next health committee meeting that we discuss this.
Yes, sir.
No
And I
action.
agree with you 100%. I'm really interested in the eyeglasses also because it's such a variation. You walk in there one day and they'll say, we've got some extra money left over. The glasses is going to cost you $17. And then you may go back and the glasses may cost you $200. And yes, I agree with you. I'll put it on there.
Could I ask a question to Mr. Lay?
Yes.
Would you want to just have us review every time we're asking people to pay for these services? I'm interested in that too.
I think so, because I'm not sure. It seems like we separated dental and eyeglasses from health, and to me, it's all the same.
Right.
Yes, please.
Thank you.
And that's all. Thank you.
Okay. Next is Counselor Kevin White.
Thank you, Madam Chair. On the report, first of all, I know you've actually presented this to us at the time that after the 5% dividend, and I had lots of questions then, and I don't know why it suddenly, because these were issues then, I guess. And not just, I think the law, I don't know if we're going to revisit the law or the policy or both, but the law specifically states that 5% set aside for eyeglasses, dentures, prosthesis, cancer, and hearing aids. And I think all those need to be brought back to the table and part of our healthcare system. And they all need to be looked at. We may even need to add behavioral health, and there's a lot of treatment that needs to be sought, because I know at Claremore Indian Hospital, which was specifically my heartburn, not with the 5%, but with the law not addressing the disparity between 11 of the 14 counties where they're not getting treated, But I would also like to know what the impact would be to bring forward behavioral health in terms of using the 5% for like treatment facilities and such for depression, alcohol, drug abuse. We need to, what would be the impact if we were to add that to the 5%? But so the law says that, and the policy is strictly up to the executive branch, because I posed those questions to Chief Baker. That is his decision. You know, I'm sure that he'll rely on you guys as experts in the health department, but that is not, you did show it to us right after, but that's his decision, not ours. Unless we just want to amend the law and specifically state what he does have to do or not in that policy and make it more cumbersome in terms of a legal context. But I think we should be bringing that forward. And I don't think it should necessarily be income-based like that. I mean, or we need to up the income requirements. Maybe if you're a millionaire, no, we're not going to give you dentures, but
Sure.
I don't know what that looks like. But I hope that we give an economic impact. And I'm specifically asking for behavioral health. Now, in terms of your report, can you give us an idea, and Brett may have to come back up, but like, for example, on this month, you're reporting that 4 were denied and there's 46 pending. So in terms of, and I know we're not disclosing, I want from a statistical, I want to illustrate what's really happening. So, for example, can you tell me the kinds of medical issues that would be denied? Maybe here, what would be denied? Is this asking for cosmetic surgery, or is this something else? What would be denied?
Maybe an MRI that didn't meet the medical necessity guidelines.
Okay.
That happens. That's an example. We have, MRIs, EMGs, a lot of diagnostics have certain medical necessity guidelines that we're going to apply.
Okay, so that would be the same as like an insurance would probably deny that, same as this is a provision. So what does it mean if it's pending?
It's one of those that is an unplanned, it's emergency room or ambulance call. So it's we don't have an answer yet.
Okay, so it's in the system, and it's only been in the system for a short time. So you recognize it on the statistics, but there's just been no decision.
Often the ones you guys reach out to us about are ones that it happened Friday. We don't have it in the system yet, and even next week it'll still be pending.
So you're just accurately reporting. Okay, and so this is not the deferred like our constituents would see at IHS, where they've said, yes, we want to pay it, but we have no money, and you'll never get paid, or it's going to be 2 years after your credit's disrupted. So are we still getting good communication from Claremore?
And we had a meeting with them. They have hosted us and a few other crowds, and we talked to them a couple times a week.
Okay, because it appears like it's going, we have less email traffic.
Yeah.
So it appears from a constituent's perspective, where we would see the patients contacting us, that it seems to be going better. Last meeting, I asked for several things, and I know, so this is not, and I haven't had time to organize my notes. But, I think, didn't Dr. Grimm kind of present last time, and it wasn't, thank you, Brett. So, on this, I never, unless it's in my email inbox and I've somehow overlooked it, the estimated financial impact to Cherokee Nation Health Services through the fiscal cliff. I don't think I got the briefing report. I mean, it was verbally said that it would be 11 million or 8%. So is there a more detailed report on what would actually happen?
I may ask Ms. Horn to address that. Would you mind?
In terms of our health department?
Well,
Since Dr. Grimm is not here, and I don't know, I don't mean to put you on the spot, but if you would mind.
I do know that Health had that report ready for distribution to the council, and our financial analyst in finance was working with Amy Sams to revise the number because it's no longer 8%, and we're getting conflicting reports between 5.1 and 5.9, so we're probably just going to blend that and probably about 5.5%. So I'm not sure where that was. I know that Chrissy had worked with Amy on that and hopefully sent it back up through the chain back up to Connie. So it may just be waiting on Connie's final approval before it reaches the council. That's my only assumption.
Okay, because I think I asked a month ago at the last meeting, and then I followed up by email. It was like on January 16th. So There is a couple of new questions, and maybe that this will be answered later under the health plan agenda item. But, we've had all these news reports, but I still have no idea as a legislator of the tribe what we've actually purchased, what it looks like, what the legal description is, what it means, where there's a plan. I don't have a plan, and neither do I even have details on actuals that have been done, and that's disconcerting to me. Then I have another question. Are we making Tala City Hospital dress codes for Hastings now? We're asking employees to purchase matching uniforms out of the blue overnight with their out of personal pay? Thank you.
May I ask Mr. Hale to address that?
Yes.
Fair question for you.
We had implemented a professional appearance policy, and we were given about 5 months' notice about what their colors would be, and some of the units that have direct care personnel were asked to comply with the standard color. They were allowed to pick the color as a unit. So like nursing chose navy blue and maroon, dental went with black and pewter, pharmacy went with royal blue, and they were given a few months to implement that. We wanted to give them plenty of notice because they would have to buy those out of their pocket.
Okay. And it was 5 months specifically, and you did it in writing to every employee?
Yeah, we actually gave them plenty of time to pick.
Okay.
And
all right, very good. Thank you very much. I appreciate your time. Thank you, Madam Chair.
Yes, Councilor Garvin.
If Connie's watching, I just want to tell her to get well real soon. I know she's been fighting that a long time, but I have one other question.
Yes, sir.
Last month, we were told we were 26 doctors short. That was before the increase in salary. Do you know exactly how many short we are now?
Again, the number I'm going to report to you is with letters of intent. These aren't signed contracts. There are some that are, but there's a combination of letters of intent and signed contracts. And our estimate with letters of intent is that we're 15 short, 15 vacancies.
Thank you.
Pardon me? But it's a combination of letters of intent and contracts. That's what I got from Kathy Kilpatrick this morning.
Councilor Berg, I think you're next.
Yes, Dr. Montgomery.
Yes, sir.
The motor fuels was negotiated around 96, 97. It's a 20-year compact. I helped negotiate that. At that time, I remember it just said health care was one of the components that we would address. That's been changed since then, obviously, since looking at the discussion that we're having today. If you get a chance, look at the original compact negotiation, because I think there's like 2 or 3 components that we addressed. And when we just said health care, we didn't break it out like it's broken out today. Okay, that's one. And that's 20-year compact, so we got another 5 or 6 years left on it. The other is I commend you on addressing the diabetes issues that we have here at Cherokee Nation on the award that we received. And I have a comment for that. There at our facility we have here in Chautauqua, there's an average of 400 to 450 that go through there every day. The other day there were 650 people that goes through that facility. And I was home in Sequoia County over the weekend, and I was telling them about our facility, and they get upset, saying, yes, you guys have it in Cherokee County, we don't have it here in our area. So I'd like to really pursue more of this prevention of health care. We're talking about diabetes, we're talking about the dialysis center. That is good, you got to have those. But anytime we run people through this facility I'm talking about, you won't see them in Hastings Hospital. The more and more we run through there, and the cost, if we would do an analysis of the cost, it's going to be much less expensive. So I would propose you put 1 or 2 on the drawing board, maybe 4, next fiscal year, north, south, east, west, however way you want to do it. But we need to get those out of Cherokee County and address other districts as well. Okay. Thank you, Madam Chair.
Yes, Councilor Thornton, you're next.
Yes, I have a few questions. I'd like to say I enjoyed Councilor Watt's questions, and I hope that we all get the answers. But anyway, my heart burns not only for Claremore, but for Hastings Hospital and their facilities. And I'm anxious to go ahead and get things started on the new hospital, but I know that's way in the future. but that 5% discretionary funding, that comes out of C&B, and that's taken from the net profits over there. But that's contract health funding, and I imagine it's for other fundings also, like was mentioned earlier. There's no sense going over them again. But I want to say that I'm proud of that act. That was an act that brought that forward. And I brought that act forward in 2007. It was passed and vetoed. I couldn't override the veto. But I like to watch this 5% pretty close. Last month, 2 months ago, I checked on the amount of funding that was in that project, that was in there, and it was almost $13 million that hadn't been taken out of it. And I'd like to see that money spent, and spent on our people and for our people. And another thing is that we're very interested in down in Sequoia County, and that's that Redbird Smith renovation of that clinic. And it's just carrying on and carrying on, and it's been month after month, and we're told that 65% drawing of the drawings have been complete. Well, that shouldn't be. That should have been done in a month with a good company that knows how to draw things up, and with y'all's expertise to do that. And I think you need to get that done. And without that, in December you've seen over 8,000 patients, and also not only that, the addition to that clinic out there, that 30,000 square feet is supposed to be done also, but it should be drawn up. It should already have it should already be drawn up. We also had the diabetes clinic out there, and that diabetes clinic needs to be used. Now, what we have to do to get a company in there, because we don't own the building, but we own the property. But those people that own that building there needs to be some pressure put on them to get that diabetes clinic in there as soon as we can get it, because we've got people that
dialysis.
Oh, dialysis clinic, yeah, but
But same thing, it's related to
I
diabetes.
imagine our dialysis clinic would turn into our diabetes also. I imagine they'll move them over. But we need to get that done. I mean, we're sitting here month after month, and that building's been built for 2 or 3 months. I mean,
Longer than that.
longer than that. But somebody needs to work on down there at Sequoia County, and we'll be looking forward to y'all doing that. And I'll be checking into it, and thank you very much.
I would like to respond, and I know that the situation in Sallisaw it's been challenging from the first day that I came here. And I think that when we first were confronted with that problem, we had hopes that this would be an easy fix and that things would be cleaned up in a month, and whatever remodeling needed to be done would be done in 3 months. Well, obviously it's turned out quite a bit different. I just don't think that anything I'm going to say will necessarily, your concern is that get open as soon as possible, and I respect that, and I really have that same goal. All that I think the important thing to say to you is that we are meeting every week, with a rare exception because of other things that come up, but we're meeting weekly with the architects, with the other people involved, the construction people, trying to make this, just keep our eye on this, keep focused, not lose sight of it, not take our hands off the wheel. I really want you to know that's what's taking place. As an administration, we obviously have to deal with a variety of different things that occur all the time, that kind of occur unexpectedly. But the Sallisaw Clinic is the one thing that we meet on weekly. And I just hope that'll reassure you to some degree that we have our hands on the wheel, that we're looking at what's ahead, trying to make things happen as quickly as possible. I hope you find some reassurance in me telling you that.
Well, it is a little bit, but I want to tell you that this body meets several times a month.
Right.
But there's some things we can't get to and some things we can.
Right.
But, I mean, the funding is there for you. So, you know, there shouldn't be that much of a holdup. The chief and the administration of the health department told us, you know, they'd clean it up, said in 3 months it'll be renovated. Well, there's something there, and it needs to be looked into. And if, you know, this body needs to look into it, I guess we will. But the thing about it is, I appreciate what you've said.
I think the other thing to do then is next month, either myself or Ms. Davis come back to you and give you a rough idea of the timeline, where we're at, where we'll be, and I think that would give you a more definitive idea of what you should expect.
Yeah. Okay, thank you very much. We'll look forward to that timeline.
All right.
I forgot to comment here. I echo the same sentiments that he has. And I knew from the beginning it wasn't going to be a quick fix. And I understand all about the renovation of the main building and the plans that are being made and everything. But I guess what really I can kind of say I'm kind of upset about is the slowness, the failure to open the dialysis center when the building has been sitting there ready. And we're depending on Tahlequah City to work out. Last thing I heard was it was with DaVita. And they were over there working, testing, and there's still the facility's not open. So do you have any idea of the latest problem that's holding up the dialysis center being open?
The dialysis center is a partnership between Tahlequah City and DaVita. And the holdup that I'm told about is with DaVita. And DaVita is an entity that we have very little control over. And the ultimate card that you would play would be to say that you want to do something different with the building, which potentially would delay things even further. So that's the answer is, 2 entities involved with opening the dialysis center, principally DaVita, have been the holdup in getting that open.
Well, I do not like to micromanage or stick my nose into the business where it doesn't belong, but I have been tempted so many times to pick up the phone and call Brian Woodruff at Tahlequah City and say, exactly, please tell me what is going on here with DaVita, because we've skirted around with them for 4 years. They didn't want anything to do with us. They, I understand, have thousands of dialysis centers all over the United States. And now we've got the big fine facility sitting there, and I guess I kind of agree with you. If we just dumped them, it would still be slower in ever getting it open. But this is really, we've got people down there that live right near the clinic that are blind, having to go to dialysis and ride the bus to Stillwell with nobody to accompany them. These are real people with real needs that I hear about all the time, and that's been my passion. When I first ran for office, that was one of my campaign pledges. I thought, oh, this is 5 years later. She's pretty slow on getting anything done. But it's not because it was a campaign promise. It's service to the people. That's what I'm all about. And I just want to see it done. And like I say, I'm dependent on Tahlequah City, but somebody has really let us down because it should have already been open.
Ma'am,
yeah.
In this dialysis clinic by DaVita, I think in that contract it says that the Cherokee Nation can pay for that building at any time. Is DaVita the only dialysis clinic or program that we can go into if we was to buy that building back?
No, I mean, that would, there would be other entities that you could try to bring in, but it would be a real challenge. We try to do it in-house, but that's just, again, that's a very significant step that we just haven't.
That's why we started.
Well, I have sent those same types of communications to Mr. Woodruff that you talked about, Councilor Fulbright, and I will continue to send them, and I'm sure he would be receptive to your concerns too, because I do think that's the kind of pressure that we have to apply that will hopefully eventually lead to that dialysis center being open.
Well, I have spent many, many hours on this with trying to partner with the dialysis center at Fort Smith, and they basically told us, bug off. We got more than we want to deal with. We're not interested in coming over to Sallisaw.
Right.
So it's really hard to partner with anybody. But since DaVita's got clinics all around us, I'm hoping this is going to move forward rapidly. That's all I can say, because I think changing to somebody else would even delay it longer. So I just hope and pray it will hurry up, because there's such a need there for it to be open.
There are a couple of doctors around that want to manage that clinic, from what I understand, when it's open. Thank you.
Okay, next is, Councilor Lay, did you have another question?
Oh, yes, ma'am, thank you. And it's along these same lines. I wonder if I could get our general to review all those contracts. And by now, it seems to me that somebody should be in breach. And if they are, let's just start all over.
Which contract is that, sir?
The one between us and Tala City. And I believe it's Tala City and DeVita. Is that correct?
That's correct.
Did they have a previous contract, or do you know about it?
I don't know.
Councilor Lay, may I interject here one
Yes,
second?
ma'am.
What I was told was that Tahlequah City was going to manage it, and they had a position that was capable of doing this, but then I heard that he had left or changed his mind, and then we went back to DeVita. So it's really hard to get someone capable and experienced that wants to do it. That's, for information, that's what I was told.
I will pull all applicable contracts and take a look at them and give you a report.
Thanks, sir, appreciate it. And I guess, well, I'm not going to beat a dead horse. This relationship with Tahlequah City and us, every time I run across one of these things, it seems to be not functioning correctly. Let me just put it that way. And perhaps y'all in the hierarchy of health could kind of look at that. I understand we've got a couple of doctors now that are working at Tahlequah City. One of them's hired by us. Is that correct?
You mean,
Recently.
I believe the contract that we have with them is still pending. Yeah. Yeah.
Not in place.
It's not in place.
They were hired by Tahlequah City Hospital. There was at least a question of whether we were going to hire them as well, and that's still up in the air. It's been there with Tahlequah City Hospital.
The roof at Redbird is, I'm being told, is sitting there waiting to be put on. Is that correct?
It's on.
It's on.
It's on.
It's on. It's all news.
The contract to finish that, did we change architects between when we started?
No, it's still Childress.
But we're redrawing something, and I don't know why. Why is it?
Well,
the redrawing is
there was a remodel of the old building, and then there was a whole new addition to the administrative building that has contributed to some of this delay. You know, the original intent was to just remodel the interior of the old building.
Right.
Then there was the notion that if we're going to do this, we might as well increase the size, increase services, put in a mammogram machine, a variety of different things.
In the present Redbird Smith Health Center?
As an addition to...
So that's what I'm talking about, the present.
But some of the services that are in the old building are going to be due to the annex. And so because they're changing what services are going to be in that old building, they couldn't just rebuild it as is, because it's not going to be the same services. And so it messed with what was happening with the expansion.
So we haven't got those new plans.
No, we're very close, I think.
Okay, who's the contractor for that building?
Mike Ross.
And let me ask, did he go through the bid process?
Yes, he did.
There were bids
Yes, he did.
process? There have been some problems with that contractor. I'll leave it at that. Thank you, Mr. Chairman.
Thank you. Councilor Garvin?
That's all right, he answered my question.
Okay, Councilor Fishenhawk?
When you do your report next month, could you report on the vacancies that you talked about? And then also report them by clinic and maybe your customer satisfaction, because I'm looking at the customer satisfaction on here, and they're like 93%, 94%, 88%, they're fairly high. And your toe in and toe out on the same report. Okay, and then when we was talking about glaucoma, I thought the plan was on these new clinics, we were going to have a workout center in all of them for the public to be able to use in the new clinics that we're going to start building. Is that not on
There will be, again, I can't address all of the clinics. The only plans that I have seen thus far that have to do with Sallisaw, and there will be a workout room in that clinic. Now, moving forward with all the other clinics, I think it all boils down to, can you finance it? Is it affordable? Can you pay for it? So I would argue, let me say that just talking about the other buildings, let me report that back to you at the next meeting.
Okay. And is Sallisaw going along the Bonita or the no water design?
I'm sorry?
The no water design?
No, I'm sorry, Sallisaw? Sallisaw is utilizing the existing structures that are there. And then there are two separate facilities. There's the main clinic facility that was there, and then the administration building that was there. The old facility there's going to be expansion of dental and optometry in that building and some other services. And then there's a whole separate addition that's going to go to the administration building that will house the primary care services and the pharmacy. Again, I think the best way to update you on that is to potentially bring you some drawings at the next meeting so you can see it yourself and see what's planned.
Okay, the other thing is, they were talking about doctors and sharing the talent ball and how that they just thinking about hiring a couple that we was going to share with.
Yes.
Could you please give me their contract? Because I would like to see what we're paying the doctors for sharing with Talent Ball City compared to what we're paying our doctors. Okay? Thank you.
I would like to make a comment in defense of the services that Tahlequah City does provide. We send a lot of people over there, and they're very happy with the way they're treated, the follow-up calls, and the friendliness, cleanliness. A lot of our people are satisfied to go there. But I'm happy to report when I met with Dr. Duke, she's our medical director at Sallisaw, and she had told me that she received a directive from Dr. Steelberg that we have a new contract at Fort Smith with the old St. Edward's Hospital. It's now called Mercy Hospital and Cooper Clinic. I just said, wonderful, because we only had a contract in the past with Sparks. And under Dr. Steelberg's directive, everybody east of Weber Falls that preferred to be referred to the Fort Smith hospitals, doctors, and clinics could be. And that's what a lot of the people in that area want, because so many of them are referred to Tulsa. And older folks, the traffic is just too bad. It's 110 miles, even further on the eastern end of the county. And so there is a lot of good progress being made. And I know that so many people that have been sent to Dr. Camille and the Heart Institute over here just sing his praises. The way they're complicated surgery, not just bypass, but new heart valves and things like that have really turned out well. So I don't think our partnership with them is necessarily bad, but we need to keep an eye on it, and we're trying to provide the best services for the most people, the least amount of money. That's kind of hard to do. But I'm not going to sit here and say I'm real happy about how slow it's been at Sallisaw. I get so many calls. I go to church down there. I go to all the dinners and functions, the Chamber of Commerce, everywhere I go. Even Walmart, people are, when's that dialysis center going to open? So I'd like to see it a little bit speedier, but I do understand the wheels of the Cherokee Nation can turn pretty slow at times, but there's a process, so I understand that. Do we have anybody else that wanted to speak? Councilor Watts?
Thank you. One of the things that on my list I failed to remind you, and I think I've been asking for this one's a little bit firmer for 2 or 3 months, is a list of how it's actually been spent. I know that you have a list by county of those served, or by town, under the 5%.
This is the 5%?
But we need actual breakout on the contract health service, like medical needs versus what else is in the legislation, the eyeglasses, the dentures, the prosthesis, cancer, and hearing aids. We need that broke out, and also by county as well, on actual spent. And I've been asking for that and haven't received it. So in a week, not next month, so I have this same discussion. Thank you.
Thank you. When Councilor Thornton said last time he checked on it, there was $13 million in that 5% fund. And I am not hard of hearing, let you know, but I've been over there to the audiologist a lot. And the last doctor, Dr. Hale, told me that just about every elder that came in there that needed a hearing aid, we gave them one, but he said almost all of them need 2 hearing aids. And to have 2 hearing aids, they have to pay $200, and they just don't have it. So they just walk right on out the door with one and think they're real good hearing with one ear. He said, we really need some more funding to give those, especially in some cases, and children, the 2 that they need. And so I would like to see that money spent. Dentures, eyeglasses, whatever it is. If we've got it sitting there, let's use it. Yes, sir.
That's a great point, and that's, maybe we can get with that next month. I don't know that we're all on the same page on how this money is supposed to be spent. It sounds like you guys are saying, let's go spend it. And we're telling you to spend it. And we've given you the direction to spend it. What for? I mean, it's a good list. Maybe it's not perfect, but it's a good list. You don't want to spend it for dentures. You don't want to spend it for hearing aids. My people get denied out of Claremore, and we still have trouble getting hearing aids. We're going to talk about everything you want to talk about, eyeglasses, dentures. You just keep going down the list, and every time I get a call, I send it to Brett, and that's fine, but there's a lot of calls I don't get, or Chuck doesn't get, or Meredith doesn't get, that won't already, probably the folks in Rogers and Tala County don't get every call. The people just go home and do without. So we need to be doing a better job here.
I agree with you 100%. We can't do enough for our elders that if they want to enjoy their old age with some good dentures and eyeglasses and hearing aids and sit on the front porch and rock, let's fix them up.
That's right.
So
Thank you.
I want them to have it. And if they need 2 hearing aids instead of 1, I want them to have it. If we have the money there.
Well, we should.
Well, Dr. Montgomery, I thank you for the wonderful report. Oh, Councilor Keener, I didn't mean to leave you out.
Thank you, Madam Chair. There is one number here that is measurable, and that's the 96% on contract health services. So about a year ago, it was 96% too, but that was just for one area. So now, this is inclusive of Claremore area too, correct?
Correct. Yeah.
Yeah. So, as Ms. Councilor Karen Watts asked, we would all like to see that before and see how that's used. But that's a significant increase, and I think you said earlier you're at the wheel and paying attention, and that's a significant increase because a year ago it was 96% for one area, only 51%, if memory serves me correctly, for Claremore. So with those two combined, that's I don't know what that is in dollars combined. I know that you've got the cost over $2 million. But that's a really good step in the right direction, so I'm applauding you and your staff for that. Thank you, Madam Chair.
Dr. Montgomery, I want to say thank you, and you're such an asset, and you take the time to answer everything. I really do think you're doing a wonderful job, and you try to work with us, and sometimes we may seem a bit cranky or harsh, but we've got the best interests of the Cherokee people at heart, just like you do, and we're all trying to get to the same page. And I don't want you to feel like we're up here berating you or asking you a million difficult questions, because we're just trying to understand things better. And I really do appreciate the job that you're doing and all of the medical people, Connie and all the team. I think we're making some wonderful improvements.
Well, along those lines, one other thing I did want to report on, it was part of the agenda under new business, excuse me, it's still under old business. I think the most important thing is services. I really do. Services for our citizens. But you've heard me say this before. Part of providing services is providing our providers with the right tool. And on the agenda, it discussed an update on our electronic health record. And we have sent out requests for proposals on a new electronic health record. I hope you've all heard this discussion before. This is an important step for our health system and our providers to have the tool that will improve their efficiency and allow our system to better keep track of data like this, what we spend in contract care, what it actually goes to, how many patients we see, toe in, toe out time. That's part of what a computer can do for you if it's a well-integrated computer system for your whole health system. And we currently have a system called RPMS, which has been around for several years and has functioned well at a certain capacity. But our growth, the number of patients we see, the number of providers we have, our growth has exceeded the capabilities of that system. And so we sent out a request for proposal for a new electronic health record for our providers to utilize. And we have received back 6 proposals. We've narrowed that down to 5. One of those did not meet the specifications and was not adequately accredited by the Electronic Health Record Accrediting Agency. And this is one of the proposals. This is another. To give you some idea of the complexity of the type of agreement and the type of system that you're looking at to enable your physicians to do their job. This one is from a company called Cerner, a vendor. It's out of Kansas City. The other is called Ocean. I can throw these other names at you. But I wanted you to be aware of this. This is a significant part of my energy and what other people are working on. And we have a preliminary screening that should be completed in about 2 weeks. And after that preliminary screening, we will invite the providers to provide input. We will narrow things down, and these vendors will come and do a site visit and demonstration so that our people, our employees, can look at this and see what they like about it or don't like about it. But our hope is that in 3 to 4 months, you will hear about our decision to work with a new vendor and have a new electronic health record for Cherokee Nation. Things that you've asked me about, these questions, they are the most important thing because they have to do with services to the citizens that you represent. My job is to straddle the fence both ways, to try to do what's best for the citizens and patients that access our health care, but it's also to represent our providers and try to provide them with the tools that will allow them to do their job more efficiently and with more quality. And I just wanted to show these things to you to make you aware of it. So, do you have any questions about this?
Councilor Lang.
Will it provide a one-chart number throughout the system?
It should, yes.
If it does not, then it's not worth that. Okay, it'll do that.
Councilor Kellen Watts, this is really your topic here that he covered in old business, but he went on to it while it was up there. That's okay.
I apologize.
Do you have?
Well, I would like to have that agenda item so that we can properly
Okay.
address it.
Okay.
I didn't know what this was.
Well,
so-
he just said he had it
I
ready.
misunderstood the agenda, and I apologize if that
That's
was
okay.
inappropriate.
He just skipped on down there, and I didn't want to tell him, whoa. So we'll come back to it here in just a minute, Dr. Montgomery.
It's okay. I think it deserves more attention, and you have to start at the beginning, 101.
Okay.
What an electronic health record is, that budget.
Right.
I think it was a review of the budget because we took money away and a status on the project.
Right.
I think there's a lot of assumptions about where people are at on electronic health records.
Okay, I thought this was already part of the
Okay, we will come back to it here in just a minute.
That's wonderful.
Okay, I think that concludes the health services report, and then we move to all business. It's GMP 244, Jack Brown Center status update for discussion only. The sponsor is Councilor Kellen Watts.
So they're supposed to be here to update us on where we're at on the build.
Unfortunately, Dr. Grimm was to be here, and his travel plans didn't get him back here in time, so I'm
Make
asking
the motion to table for 1 month.
Second.
And would ask the chair to work with health to make sure somebody's here to present.
Okay.
Thank you.
apologize for that.
All in favor of tabling?
We need a second, I think.
He seconded
Okay,
it.
I didn't hear it. Thank you.
Respond by saying aye. Table for 1 month.
Aye.
Opposed, same sign. Okay, we'll table this for 1 month, and we'll try to make sure that Dr. Grimm is here next month to report to us. Now we're moving on to the electronic health records. Councilor Watts.
Well, I would suggest that you kind of give a basic overview on what electronic health records are and our requirements. I think not only under the Affordable Care Act, but I think we had already a project underway.
Meaningful use.
And then, you know, where we at is what's the impact to our constituents, if any, what would they see or not see?
Right.
And financially, are we on track to implement after, I think we took $1 million away from it or something on the AIS.
Yeah, we have projections on what that will be, additional funds that will be available through meaningful use. You know, I apologize for getting out of line on the.
That's okay.
You're fine, don't worry about it.
Again, the RFP was sent out a couple of weeks ago, several weeks ago, and we received the 6 requests for proposals from 6 different vendors that provide the electronic health record. When you go to see your doctor, nowadays they don't take notes with a pencil, and they sometimes don't even look you in the eye. They spend a lot of the time seated in front of a computer entering in information. They enter in your symptoms, they enter in your age, your medications, and that all goes into a central computer system, which is the electronic health record. If you go to the hospital and see a doctor in the emergency room, that same type of data, is this okay? Is this where I should go? Okay, good. That same type of information will be entered in by that emergency room physician. If you get admitted, the doctor that sees you up on the floor will take his notes, put his history in there, his physical findings, all in that computer. And the electronic health record is a system that communicates all of that information wherever you go. We started in the Salina Clinic and came to the emergency room, got admitted. That information now seamlessly passed from one location to another through this electronic health record. Your provider then can enter in orders, can order medications, can order x-rays, can order a variety of different things, can order service referrals for behavioral health, all via the computer or electronic health record. So we've had a system in place for several years now called RPMS. It was unique to Indian Health. And it has evolved and improved, but it's kind of reached a plateau where it's just only able to do so much. And our needs, based on our volume, the complexity of the services that we provide, has exceeded what our current electronic health record can do. So we feel that we need to look towards getting a new vendor, a new company that will provide an electronic health record for Cherokee Nation Health System. And when we made that decision, we sent out a request for proposal, and we received back these responses from 6 vendors, 6 companies. These companies include Cerner, Epic, NextGen, I can throw you the names out, but they're all large companies that have systems or computer systems that would meet the needs of our system, in theory. And so again, we're at a point where we're doing a preliminary review of those proposals. We've narrowed it down to 5, but we'd like to narrow it down a little bit further. Be sure that they'll meet the needs of our system and fit within our budget. And these systems vary in potential cost from $11 to $22 million over 5 years. Those are the preliminary numbers that we've received looking at these proposals. So again, we're screening them. We're going to try to narrow it down a little bit further, and then we'll go through a further process of evaluation before we make a final decision on what system to hopefully contract with. And the decision about the affordability is we're putting it off a little bit longer. We think that we can do it because of the money that should come to us through meaningful use and other potential sources. Now, meaningful use, I throw that out there. I know what it means, but you guys think, well, everything should have meaning. There's funding through the government. If you show them and prove to them that you're using your computer system and your health system effectively, if you're putting in the right information, collecting the right data, and then spitting out the information in a meaningful way that your providers do things differently or behave more efficiently, the government will give you money for that. And that's what meaningful use is. Did I explain that okay? Does that make sense? So we hope to, from meaningful use, recoup, the number is variable, but it could be anywhere from $4 to $6 million, which would go to we would like to apply to the cost of purchasing a new electronic health record. There are some strategies that we want to employ to try to pay for this that haven't been finalized, Councilor Watts, but those are the preliminary notes as well. Does that explain things reasonably well? I know it all makes, I deal with this every day. So.
I've got a question right here. I understand electronic health records pretty well, but I have a hard time explaining to all my constituents who walk in at Redbird Smith Clinic, and some of them can get pretty gruff, and the constituents, they ask them, or tell them, I need your blue card, your white card, your driver's license, your insurance cards, and the constituent says, nothing has changed. You've got it all. I gave it to you once already, and everybody that comes in the door. So I asked the administrator what is going on, and he said they had sent all the electronic health records to Hastings, and they were having, I don't know if they lost them, or they're in the system somewhere, but it's really aggravating to people when they walk in, and they've been going there for years, and they've given them, most people do not carry their blue card and their white card with them. And Councilor Watts, are you trying to tell me something?
Yeah, point of order. I can't hear because people are talking and whispering.
Oh, I didn't know anybody was talking.
Maybe I just can't, maybe
I'm sorry. Everyone, please. Yes.
Can we also ask not to be typing, because I hear a continuous clicking going on.
Okay, we need some quietness in here. Back to my point. Is there something particular going on down at Redbird Smith Clinic where they are asking for everybody's credentials new again? And then one lady asked, well, why are you doing this? They said, Medicare requires that we update everything every 90 days. You know anything about any of that?
Well, I don't know anything unique about Redbird, I don't. But I do know that part of the success of our health system is to periodically be sure our information is correct, because if it becomes outdated and you don't have up-to-date insurance information, we risk not collecting those monies that go towards our system.
It's
I don't know if that's the
kind
answer
of
that
a unique situation, because I know people that have been going to the clinic for 20 years. They're kind of professional type people, have good jobs, you know. And you ask them to register to vote, and they don't even have their blue card, and they've been going to the clinic all those years. And I thought, these other people, every time they go, they want to see their blue card. Of course, you can be treated forever up there and just have your white card, but I'm not against them cracking down on making people getting their card. But then they all say, they're aggravating me when I go in up there. They want this and this and this, and I've gave it to them so many times already. I said, well, all I can tell you is you're going to have to give it to them again.
Yeah, I will check in and see if there's something unique, but I don't think so. I think most of that, again, is just to get updated information about potential sources of reimbursement that might have changed since someone was last there. I think that's
Well,
the best
people
way.
are pretty well trained when they walk in. The registration lady always says, has your insurance changed? They've got the best mailing address system of anybody. I mean, I understand all that, but to ask everybody that walks in the door to resubmit all their credentials, it makes people mad.
I'll look into that further.
That's as easily as I can put it. Go ahead, I'm sorry I interrupted. Yes, Councilor Watts.
Thank you, Madam Chair. So I was concerned when we saw the decrease in the budget for electronic health records. So you're saying we still need to expend the money, but the plan is, or the strategy is, that we believe we'll recoup the cost,
Some of the cost, yes.
or we'll get revenue from the project in order to make up for the decreased budget. We're still going to spend it, and we'll still need it, but we're hoping we're going to get this revenue over on these other or other activities that should be associated with it.
Right. And then there are projected decreases in costs that just come from the record, use of the improved efficiencies that come from using the system itself. Now that's something that's hard to put a dollar figure on. But you do have those potential increases in or decreases in cost associated with using a more efficient EHR.
Let me ask another question another way then. So we don't anticipate coming back to this body asking for more dollars in order to cover it, the decrease that
What I'd like to,
in a month or two ago, I think. So
the answer I'd like to give you is let us do the analysis and see which system we think would be the best, and then what that cost potentially could be, and then come back to you and give you a firmer number about what we would expect.
Thank you. Thank you, Madam Chair.
Councilor Fisher-Hawk.
I'd like to know how much money we have spent towards electronic health record. I mean, in the past years, because that's always our budget, and it has been for probably 3 or 4 years. and they've never got there. And I'm curious about how much they've spent in the past trying to get there.
It's a very appropriate question, but it's not something I have
Yeah.
top of my
Could you
head.
report back to us on that?
Report back to you.
Thank you.
You bet.
Yes, Councilor Keener.
Thank you, Madam Chair. Does 11 to 22 million over how many years did you say?
5 years.
5 years. And what's the main difference between the 11 and 22?
Bells and whistles. And it also has to do with the support costs. Some of these proposals have the support costs, training of individuals to do specific aspects that manage the system are built into that projection. Others potentially have extra support costs that are outside of the original proposal. No, that's a vague answer, but it's hard to answer specifically.
You also have to look at what the support costs would be if it was in-house,
right,
as opposed to a contract. Okay, I know you're making your decision.
And that'll factor into the choice.
Thank you. Thank you, Madam Chair.
Councilor Watts, you have anything else for electronic health
No,
records?
thank you very much. We appreciate your time, Dr. Montgomery. Thank you.
Okay, and new business is Councilor Fishenhawk, discussion and possible action concerning healthcare master plan expansion.
I think that we were supposed to discuss this evening in ENF.
All right.
So I'll just go ahead and pass it since we're doing ENF.
Okay. Next is discussion and possible action, Claremore IHS Hospital billing, Cherokee Nation Blue Cross and Blue Shield, and I think Mr. Bill Foster is here to address these issues. Councilor Watts, this is yours.
Yes, I think that he has a plan or proposal or something that's already been done. Mr. Foster, would you please present that? And I don't know if Vicki might have questions for you or not on it. The issue is that so far, Claremore Indian Hospital, since it's a federal facility, we had chosen not to allow them to bill our Blue Cross Blue Shield insurance, which cost our Cherokees in that facility in that area, I think a couple of $100,000 a year in third-party revenue that could be used, to do things that need to be done at Claremore Indian Hospital because we don't support that facility as Cherokee Nation.
Okay. That could possibly be true. I would make that statement with a little side mark on that thing. Right now, let's say we went on ahead and removed the exclusion from our health insurance, which the IHS facilities are excluded. Okay. And the exclusion went into effect in 2008 when Cherokee Nation took over Hastings Hospital, when they contracted, or probably started off compacted. That's before my time too. But anyway, you've got the facilities now being a tribal self-funded entity, our health insurance, and we've got the Hastings Hospital where they can bill our health insurance plan with no exceptions, no exclusion issues or anything like that. Now, if you totally remove the exclusion from your insurance now, you're not just going to pick up the Cherokees and Claremore IHS. You could potentially have, if you remove it all, remember the key word there, if you remove it all, you could have the Choctaws, Chickasaws, whomever a person may go to and incur a liability and be paid from our health insurance. Now, is it going to save the tribe money? What is the benefit of doing that? I have no idea, but I can tell you one thing, that there is a potential you may have more outlay of funds potentially than savings right off the bat. And as to how much they're going to be, I can't guarantee you that. But you will have to you'll have to write a letter of authorization from the governing body, which would be you as the council. It had to be the council's wish that you write a letter to the IHS, okay,
you've got to do it every year. It runs for a year. The one thing about it, you can write a letter now and next week decide, hey, whoa, wait a minute here, we don't want to do it anymore. So you can turn right back around and write a letter putting them back in exclusion and then deleting your agreement. And you'd send that to IHS if it's not going the way that you want it. Now, that carries a lot of different avenues there, because right now it'll take 30 days if the council were to say, okay, we want to go with it. It'd take 30 days for right now for the our health insurance to code everything and make sure it's working with the IHS facility or facilities. And then it's going to cost probably about $800. Maybe that's negligible to the tribe, but it's still going to cost you $800 for a planned document change. And then what we'll do there is what we're hoping to do is that C&B does have Claremore IHS in their plan. Okay, it's a special network of providers that they negotiated into, and then they do accept their claims. Now, here's the only reason I could see for that exception without too many headaches. The CMB is a for-profit entity, whereas the tribe is a not-for-profit. They are called government entity, which throws it into a whole new ball field when you're classified as a government entity. There are certain things you don't have to abide by. You don't have to abide by ERISA or some of those other legal requirements. We can just set that aside if we want to, because we're a government entity. Now, if it should be the council's wish to do that, you'd probably have a 30-day waiting time. Then you'd have to give us directions as to, okay, do you want to open this up to all IHS, or do you want us to try to just specifically name Claremore if we can? No guarantees on that. We may have to take them all in. I'll just tell you that up front. But if it comes out just Claremore IHS, well then that's great.
Councilor Watts?
Thank you, Madam Chair. I understood when we, I think, communicated by email before a little bit different situations. So some of this is news to me right now. So do we today, as a self-insured Blue Cross Blue Shield plan, do we allow Cherokee Nation Health Services to bill our Blue Cross Blue Shield employees?
When you say Cherokee Nation Health Services, specifically WW Hastings?
Hastings, Salina Clinic,
all
Muskogee
of them.
Clinic.
Any health clinic that's under the tribe, Cherokee Nation. The clinics are covered. WW Hastings is covered. And then your little clinic up here on the hill, where Godoogie, I think it is, if I'm not too badly snake bitten, they would be covered. So we
And they're specifically named, or Cherokee Nation Health Services is specifically named?
It would be all listed all under the Cherokee Nation Health Service. I'm sure that our insurance company has them all listed. Yeah, I don't think they'd go
Because
without.
IHS funds those, and it's a government
That's right.
deal. So, I mean, because the way I understood it was we couldn't just name one. So you're saying we can just name the Claremore Indian Hospital?
No, I said we may try to. There's no guarantees that we can do it. You may have to pick up all IHS facilities.
But we're only asking that people, as employees of the Cherokee Nation, their family, under our Blue Cross Blue Shield plan, that if they happen to go to those facilities, which is pretty unlikely, because since most of our employees are here in the 14 counties, that it would be those that would be going to Claremore Indian Hospital that would be billed, or those impacted by Claremore Indian Hospital, like through inpatient, outpatient contract health.
But if you don't have an agreement with Claremore to honor the billing, the service billing, well then Cherokee Nation will just ignore them, just like they're doing now.
Madam Chair, may I ask Vicki Snell to come forward on this issue?
Yes.
Because this was at our last, well, it's been at several board meetings, but it came to fruition, I think, at the last board meeting too, and then, would you talk to that?
Yes, we had started billing, because our legal counsel had told us to continue billing, and then after about 3-4 years, we just ceased because, we knew we weren't going to be compensated. We quit looking at those numbers, so I can't tell you today how many patients are impacted, but I can tell you of some of the things that I've experienced in contract health. I helped a gentleman a couple of weeks ago who's employed, at the casino and was being referred, and he was wondering why his deductible hadn't been met. Well, he'd only been seeing us, so we weren't billing for his health care, and so when he had to be referred, his deductibles had not been met. So we were going to have to meet those as well.
So Vicki, what I hear you saying is different than what I heard, or what I understood Mr. Foster to say is that even the casino, CNB is or is not billing or allowing billing for Claremore, or they've not notified you.
If they're telling us they're employed by the Cherokee Nation, then that's going into the employer file, and then it's not being billed.
Okay, CMB should be honored billings from Claremore IHS because they set up a special network for their providers. And being a for-profit entity, they got a little more leeway. So they should be billing CMB's plan.
Vicki, would you follow up with our counsel by email after you find out what the case is?
And what we need to go back and do is look at how many people who are employed, and then how many people, how their insurance is on file. If it's Cherokee Nation, or like if your self-insured insurance is MetLife, we need to run that versus Blue Cross and Blue Shield. And then look how many visits that we've had.
I would like to make a motion, because what I heard is we could make a motion, we didn't need anything like a formal, that he would write the letter. But I would like to make a motion that we direct Human Resources to add Claremore Indian Hospital specifically to our Blue Cross Blue Shield for billing for our employees as a government.
What if we should, I got a question, what if we have to pick up all IHS and report back, or you want to proceed forward?
I have no problem with proceeding forward because we're impacting primarily Claremore Indian Hospital, which is already second-class citizens for most of the nation because that's where they're served. And I'm hearing it's even further that they're thinking their deductible is going to be met, and all of a sudden they have to meet 500 or more deductible, and it's not going to be met because they thought there was billing the whole time. So it's impacting individuals as directly as well as the whole facility because of that third-party building. So I need a second.
Second. No discussion on motion.
We need to discuss this. It's been motion and second, but I have something I want to ask Councilor Kelly Watts. Is the point of the whole thing to receive more third-party revenue? Is that the main point, and then for them to get their deductibles met?
Yeah, and I didn't realize that I had not realized the deductible was also an issue, but it is because the Cherokee Nation is not supporting the Claremore Indian Hospital as a federal facility. It needs all the third-party revenue it can, and that further leaves behind our population served by that facility up there if we're not allowing the third-party revenue on our part.
When we get to looking at insurance, we're opening up a whole new can of worms here because, like on Blue Cross and Blue Shield, the type of policy that Cherokee Nation has, like on medication, you cannot get any reimbursement or your deductibles met or anything on that because it's a caveat in the plan that we have that medication cannot be billed. And so you're wanting, the point of the story is you're trying to increase their billing revenue.
I mean, I mean, this body talks constantly about access to health care and committing to health care, but it seems everywhere but Claremore Indian Hospital and the folks served by that area is getting access to this.
I disagree with you. I have voted many, many times to increase funding over there to get the 5% for them. We're not trying to exclude them in any way. But he's telling us plainly that if we do it for Claremore Indian Hospital, they may turn around and say we've got to do it for all. So, yes.
So can Mr. Foster and Vicki and George work together to bring back a financial impact report next month? And we'll consider it at that time, and we can table this agenda item?
Yes.
Is that acceptable? Vicki's, we see you, and you said yes, Vicki's saying yes. And you'll bring George back next month, hopefully. Okay, I will move to table for 1 month.
May I interject something here before, if I may? Okay, one thing you're going to have to look at. You're going to have to look up one section, exception to the IHS payor of last resort versus the tribal self-insurance plan. And you can find that in section 206F of the IHCIA, Public Law 94, 437, 25 USC, subsection 1621 EF. And that should make for interesting reading. I had to read it.
Could you provide that to us?
Yes, ma'am.
Could you provide that to us?
Yes, I will do that. You'll probably get an email for them.
Councilor Lay, did you have something you wanted to say?
Yes, ma'am, thank you. I think a lot of people had a lot of questions about this, and kind of the motion was seemingly to me being premature, but now it's been tabled, and that's good. There's still a lot of questions why. I asked the previous administration's health department officials why we didn't do this. And they told me it's because we're self-funding on our insurance, and it'll cost us more in the long run, was one reason. And there were several other that I can't even remember now because that was a year and a half ago. But if we want an impact study, I think we're going to have to ask a lot of questions here about what this does to our insurance, to the employee-based insurance, basically. And see, I'm at a loss. I don't know if the other employees of the other tribes that are represented, do they allow their insurance to be hit? Maybe we'll ask. If we're going to do that, let's ask them to do the same thing.
I can find that out pretty fast. From the before life I had before I came to work for Cherokee Nation of Oklahoma, is that we did accept IHS, but we classified them as out of network. So they got reimbursed at 60/40, whereas in-network was 80/20. So whenever you open it up to another potential supplier, you will incur more expenses.
And that's one question I would have. If it doesn't hurt us, it's great. But if it hurts our over on the tribe side, with 4,000 employee base, and that's a whole new.
But one
we got to think about that.
But one thing you'll have is you'll have that letter that the council's going to generate and give to IHS. It's only good for a year. Let's say you did it this month. By next year, you better have another letter if you're happy with them and that's the way you want to go, extending it for another year. Let's say you get 6 months into this thing and it's not what you thought it was supposed to be. Generate another letter, serve IHS with it, and walk away.
Another thing, we're talking the tribe side only, because CNB's got a different plan, I guess.
Right.
So the tribe side only, employees from that work and go to Claremore or doctor out of the Claremore unit area. And so how many is that? Anybody know? And what is that? I guess that's the impact study.
They probably have about 2/3 as many people as the tribe does. The game facilities. But like I say, there are they're definitely a horse of a different color since they're for profit. You know, they can probably go with the flow in a lot of cases as far as expenses. And I'll probably get shot after I make this statement, but I can substantiate the fact, is that, okay, let's say their rates do go up. Let's say they're paying $12 million a year for their health insurance, then it goes up $5 million. Okay, all they need to do is take it and pay it because that's the cost of doing business. And then whatever's left over, then the tribe just gets $5 million less of the net profit. That's bottom line.
I wonder, who knows those figures? Is it Lacey Horn's group or?
I don't know, sir. It'd be dangerous if I knew it.
Mr. Foster, I have a question for you. Maybe you can find out, or Ms. Snell, how many employees over there at Claremore Indian Hospital are Cherokee, and how many employees are there as a total? How many Cherokee employees do we have there?
At Claremore?
Yes. Can you find that out? Yes, at the IHS
I don't know,
facility.
but I'd probably get it fairly
I'll find it
fast.
Well, I've got something I want to address with Councilor Kellen Watts. As chairman of this committee, I would be derelict in my duty if I did not correct this statement. We have never, ever discriminated or treated Claremore Indian people differently from others. As I am chairman, I specifically recall voting when we sold the plane to direct a big part of the money in that direction. I have many relatives over there. I want Claremore people to be treated just like everybody else. And we're not trying to throw something in the way to keep you from getting your legislation passed. And I feel like you're being treated fairly. And I am for everybody over there, just like I am for everybody in Adair and all the other counties, not just one. But I just don't think that we're treating you bad. Any other questions?
Bill?
Yes.
Can you and Vicki, I guess, is going to run her records
And
and
look
see.
at the number of patients that we've seen that have Cherokee Nation insurance.
Okay, and then on your side, Bill, can you check and see what this, how this might affect our base insurance? Should we open it up to federal facilities that can collect from us? And can you also do some checking to see if we can even carve off Claremore and not get the other federal facilities involved? I think that's going to be the hard question right there. Whether
Right
we
now,
can
that's
pick
the
and
first
choose.
vote.
Yeah, whether we can pick and choose. Is there a way that you can find out
I
whether
could
we can do
probably
that?
one phone call find that out, because that would be the first thing you want to do, is just make it Claremore specific. But then there's no guarantees on that, because you may end up with everybody.
If it's not Claremore specific, I don't know that we're going to be able to, in a month, do any kind of study to see what the impact may be across the United States for us if we make this change. We may need a little longer to do a study to see what that cost might be, and I think we might want to look and see what the base cost for our insurance will be for our other 4,000 employees if we do open this up for more than, if they won't let us just take Claremore and do it, if it's opened up for all the United States, I would envision that that's going to cost us a lot more money. So it may take us longer to figure that scenario out.
I'm afraid you're going to be right, because right now we have no data to work with as far as Cherokee Nation and IHS facilities per se here, because it never has happened here. Because when you took over in 2008, you excluded IHS. So we've just been going along, and W.W. Hastings could build.
Can you also check and see what the reason for the original exclusion was?
Monetarily.
Well, that's what I'm thinking it was too, but
But
I
I'll
would like
check.
to make sure back in 2008 when there was other leadership and some other composition of this body, they chose to exclude it.
I was told it was financial, so I took.
Point of order, I think we have a motion to table and a second on the floor, and we seem to be wandering into debating something that in fact we have a motion to table that we haven't yet voted on.
I think we're just talking about discussion here, and everybody needs to air whatever is on their mind. And I have spent many hours.
Are not debatable and discussed. There should be a vote taking place rather than.
I beg your
discussion
pardon.
taking place.
I've got something and I want to say it. I've spent many hours studying insurance and comparing Cherokee Nation Blue Cross and Blue Shield to CNB Blue Shield. And there's a big difference in it. And the CNB has the better plan because it's more people, probably healthier people. They go into all this, and that's why the plans are different. And there's a lot to be said here. It's a big issue. And we've got 17 counselors here, and they all want to be heard. So we do have a motion on the floor to table this. All in favor to table, let it be known by saying aye.
Aye.
Opposed? Yes.
Can I ask one other thing? Would the chair entertain an idea of maybe forming a subcommittee on health again like we had a couple years ago? And maybe this issue is more suited to a subcommittee review before it comes back to this body?
Yes.
Did the speaker mean subcommittee or work group?
Work group, I'm sorry. I think a work group. Yes. Would the chair?
Yes, I would.
And would you be selecting that within the next month and get that underway?
Councilor Watts, when we form this work group, I'll make sure that you're included.
Thank you, Madam Chair.
I'll call for volunteers. Okay, I think that it concludes everything. Thank you, Mr. Foster. It's very informative. Did a good job. Chair, entertain a motion for adjournment.
Second.
All in favor?
Aye.
Let me know by saying aye. We meet again on March the 11th at 1 p.m.